Hello, I'm Charlie Overturf. I'm one of the third-year Med-Peds residents.
Hi, I'm Holly. I'm also one of the third-year Med-Peds residents.
And we're going to be doing a brief talk today about fever. In this kind of in the context, if you're a house officer at night and you get calls about fever, what you should be doing, what you should be considering, and how you should act early on to make sure the patients get the best care. If there were three things that we could focus on that we'd want you to take from this, it would be one, the ability to identify is this patient stable or unstable. Two, if you think they're unstable or meet the definitions of sepsis or septic shock, that you follow your institution's protocol quickly and get the treatment, IV fluids, antibiotics as soon as possible to improve care. And then finally, if you're ever feeling the sense that you need help, that you need backup, to call either other seniors or your MICU residents, and that they're always going to be there to help you out. All right, so first off, we're going to kind of be going over the right side of the board, I guess the left side for you guys, and saying, you get this phone call saying a patient has a fever. What are you supposed to do with it? First off, the numbers are important, all right? So the basic definitions for fever are going to be a temp of 101 or a temp of 100.4 sustained for over an hour. Now, technically, this is kind of like the neutropenic definitions of a fever. Some institutions follow this for all. Some, limit it just to the 101. But those are kind of loose definitions to think of. So you get this call, you want to ask, first off, what are the actual temps? How are they checked? And then you're going to want to get a full set of vitals, all right? The vitals are important because they're going to allow you to differentiate, is this patient stable? Are they unstable? Another set of definitions that are important to kind of think about are SIRS. Now for us in our hospital, we still use the SIRS definition. So again, this is a temperature over 38 degrees Celsius or less than 36, a heart rate above 90, a respiration over 20, or a white count over 12,000 or less than 4,000 with over 10% bands. So this is kind of like a risk stratifying system. Because when you get a call about fever, fever in and of itself is not very specific or sensitive for infection. There's multiple things that can cause it. And so you have to be going through your head thinking about your different differential, different causes, taking all this together and then saying, this is highly likely that this is an infection, this is less likely, and then knowing the corresponding treatments. All right? So again, you get this phone call, you get your full set of vitals, knowing to get the most recent set. Sometimes nurses will call you with vitals that are like 2 or 3 hours old. And again, you want to get the most recent set, ask them immediately to get a new set of vitals. And then you're going to say, is this patient stable or unstable? So if the patient's unstable, that's going to kind of change the urgency of everything. This is, when you decide that this patient's unstable, especially if they're like hypotensive, they're not mentating, if the nurse is sounding like overly concerned, you want to go and examine them immediately. Now, things that you can be considering as you're going to examine them, is this somebody that I want to start fluids on early? Is this somebody that I need to get to the ICU quickly for pressor support? Is this somebody that we want to start antibiotics on? A lot of times as you're going to see the patient, you may have like access to the chart on your phone, so you can be reviewing and going through it like that. But again, unstable patients need to be seen as soon as possible, and interventions need to be started as soon as possible. Let's say that this patient's stable. So they call you, they say, they're running a fever, they might be a little tachycardic, but their pressure's good, they look good, they're not in tons of pain or changes in mental status. Well, it's important to do a chart review. Is this a patient that has been repeatedly running fevers over the past few days? Is this a patient that's not had a fever since admitted? You want to check the MAR, which is, the medications given. Is this a patient that has been getting a lot of Tylenol and ibuprofen, things that can mask a fever for the past few days, which may be changing like the level, like maybe it's not quite as high and they're breaking through, or maybe this is something that's kind of hidden this infection for a little while and you actually may be farther behind than you thought. And then going through the associated symptoms, going through the notes of that day, were they having any focal complaints? Have they had any recent surgeries? Is this a patient with a malignancy, which can cause a non-infectious fever? All those kind of things are very important early on to kind of differentiate how big a risk the patient is for developing something life-threatening. So you've done that, you've evaluated, you've done the chart review, If they were unstable, you went to go see them immediately. And now you're going to do the exam. So it's important to have a good systematic exam that you should really do for almost all your patients. Now, first off, the vitals are going to be the most part of your getting recent vitals early on is extremely important. But then talking to the patient, a lot of times they can give you hints, or they'll just tell you straight up, like, hey, I've got this rash, it's really painful, my abdomen's hurting. They will give you different areas to allow you to get focal points on the exam that will lead to the type of infection. On the flip side, if their vitals were good, but all of a sudden this patient's altered, that is somebody that's very concerning. And so a change in mental status, even with okay vitals, is something that needs to raise a lot of red flags. Starting from that, though, listening to the heart rate, are they very tachycardic? Listening to the lungs, again, you're going through your differential, which we'll talk about in a little bit, but is this a patient with pneumonia? Abdomen, do they recently have a surgery? Is their abdomen tender? Is there any erythema along surgical sites? Again, that kind of goes into the skin as well. Do you have any concern for like a cellulitis, abscesses with like purulent discharge? Doing a good skin exam is very important. And then finally, lines, surgical sites, and again, any wounds. So if they have central lines, if they have catheters in place, these are high risk ways for you to get bacteremia, get infections. And so your examination early on will speed up your differential and your management.
All right. So now you've evaluated your patient, you've done your chart review, you've gone and examined them. As you're doing all of this, you're starting to think about your differential to try to figure out what's going on and what's causing the fever in this patient, right? So we've kind of got some broad categories of what is most likely to be causing a fever, okay? Of course, the biggest one you're going to think of is infectious, and this can be nuanced a lot, right? Because it can be broken down into viral etiologies, bacterial etiologies. You're thinking about all of your sources for all of those. So is this a pneumonia? Is this a urinary source? Is this a bacteremia? You're looking at all of your catheters to look for any kind of wound infection, any line infection, anything like that. If they're immunocompromised, you're thinking about your fungal sources. So there's a lot that can go in with this infectious category, right? Your other things are going to be malignancy. So sometimes it's going to be a tumor fever. Oftentimes your chart review will help you with that. Rheumatologic etiologies, right? So is this a patient that has an underlying autoimmune disorder that predisposes them to having these fevers? There's a lot of drugs which unfortunately can be antibiotics, it can be antiepileptics, it can be some of your chemotherapies. There's a huge list of medications that can actually cause fever as well. Neurologic, sometimes you'll get patients that have underlying neurologic issues that will cause neurostorming and will cause some fevers as well. This is the 5 Ws, which I know oftentimes we think about as post-op etiologies for fevers, but it's really a helpful way to think about fever just in general. So kind of going through these in your mind is another way to just help you remember and be like, oh wait, is there anything I'm missing, right? So don't forget about those clots, don't forget about the atelectasis, those can all be causing fever as well, okay? So now you've thought about all this, so now what are you gonna do about the fever, right? So we're gonna come down to management. One of the most important things that we want you to get out of this is, are they septic, right? Because that is something that's time sensitive that you're going to need to do something about quickly as the house officer, okay? So if they are septic, which you can go back, look at those SIRS criteria, that's what our institution uses to kind of help them determine whether a patient is septic, then probably your institution is going to have some kind of protocol for what you're going to do from that point, okay? But this is a time sensitive thing, so you're going to follow that sepsis protocol. It's going to include IV fluids for the patients. You're going to be starting the patient on empiric antibiotic therapy. The patient's going to get at least 2 sets of blood cultures, additional labs that are probably going to include electrolytes, a CBC, urinalysis, anything, a lactate, anything else that you think is indicated. And then imaging kind of based on their symptoms too. So are you worried about pneumonia based on your exam, based on what they're complaining of? Are you going to add on a chest x-ray? Are you going to add on a Doppler because you're worried about something else? Any of those things that you think that they're going to need, okay? Let's say that they're not septic though. So then this is going to be a case-by-case basis and a lot of times, right? And you're going to think about everything that you got from your chart review. You're going to think about everything that you got from your exam, and then you're going to kind of tailor your management from there, okay? Generally, you can give them an antipyretic. Obviously, look at their allergies. Make sure that they don't have any contraindication to getting some of these medications, right? But you're going to think about your Tylenol, your NSAIDs, okay? Typically, I'll have the nurse recheck in an hour. I'll say, okay, thanks, let's do some Tylenol. Recheck in an hour, let me know if they're still febrile. And then any additional testing kind of based on what you saw on your exam and from your chart review. Okay, so did you find some findings on your exam? Did they have decreased breath sounds? Did they have abdominal pain? Did they have a erythema around a line or something like that? That would maybe prompt you to do more of an evaluation based on that. But then otherwise, that's about it for the standard stuff. You're really going to use your best judgment. Your ICU senior is always going to be there to help you if you have any questions, if you have any concerns. As a house officer, don't be afraid to err on the side of caution, of course. And then, yeah, reach out whenever you need it. So, just to recap, the 3 things that we really wanted you to be able to get out of this from this lecture is identifying patients who are stable versus not stable when you do get that call that a patient is having a fever, identifying sepsis so that you can act on it quickly at night, and knowing when and that you have someone in the hospital that you can call when you need help. Thank you.